My presentation, I would like to talk about the clinical and imaging assessment of stiff elbow, surgeon's perspective. No matter it's due to post-traumatic, degenerative, or inflammatory causes, elbow stiffness is a common problem and can be very disabling. Elbow stiffness can be caused by mechanical adhesion, contracture, or blockade, or due to pain, or the combination of the two. For mechanical reason, it can be soft tissue contracture like the skin, capsular, collateral ligament, muscle tendon contracture, or can be articular problems such as arthrofibrosis, abnormal articular congruity, presence of loose body, synovitis, cartilage defect, and so on. And it can also be due to the impingement such as the fracture site new bone, the fracture fragment malunion, heterotopic bone, by the implant, by the osteophyte in the degenerative change, or by the nerve entrapment. For pain, it can be due to synovitis with inflammatory pain, nerve irritation resulting in neuropathic pain, or even chronic regional pain syndrome, or pain arising from the irritation of the contracted tissue, or pain arising from the impinging onto the blocking structures. Sometimes stiffness is the only concern of a patient. Sometimes it's associated with pain. It can be at the end range, mid-range, or throughout the whole range, or at certain position. Sometimes stiffness is associated with instability of nerve symptom or the combinations of the above. And stiffness may not be the patient's major concern. The pain, instability, or neurological symptom may be bothering the patient more than the stiffness. We have to explore from the history and physical findings what are disturbing the patient's life. In order to alleviate the patient's symptoms and meet their demand and also their need, we have to identify the culprit causing the stiffness, understand clearly the patient's major concern at his elbow, whether it was due to the range problem or pain or instability, and know their expectation. We need to take a proper history, conduct a proper physical examination, and perform appropriate investigations. These assessments are also helpful to guide us which treatment is the best for them and help in preoperative planning and predict the operative outcome. In the physical examination, after assessment of the active and passive range of motion, we also need to feel for the motion, whether it is a smooth one, and any crepitus or clicking, and feel for the endpoint, whether it is a firm or a soft one. A firm endpoint signifies that contracture, adhesion, or blockage is mature and firm. Then we can predict the conservative treatment won't be effective and find out any end range impingement tenderness will signify the blockade causing the impingement. We also need to locate the exact site of the tenderness. That's very useful to help us to locate the pathology and then subsequently tackle it. Tackling the painful pathology usually gives good patient satisfaction. And also we have to look for any instability, feel for the outer nerve for any thickening, subluxation or tenile sign, and do the special tests accordingly, including the test for the bicep tendon instability and etc. The imaging, such as the X-ray, ultrasound, CT, or MRI, can help us to confirm the diagnosis if we already have the pre-existing professional diagnosis after the clinical examination or clinical history, such as in this case, a 47-year-old man complaining anterolateral elbow pain. He was unable to extend the elbow fully because of the pain, and the physiotherapy was not helpful on him. He was unable to lift weight in the gym. He was found to have tenderness at the ECLB tendon with a wrist extension against resistant painful. At the same time, he was found to have a hook test positive and also elbow flexion or forearm supination against resistant painful. In this juncture, we think the patient may be suffering from tennis elbow and also the bicep tendon tendinosis. The X-ray was normal. However, the MRI clearly showed that the patient having the distal bicep tendinosis and also the partial tear of the common extensor tendon. So that means that further imaging confirms our diagnosis and that we know how to treat the patient despite the clinical signs are not obvious. Imaging is also helpful to give us the causes of the stiffness or associated symptom and also offer us preoperative planning, such as in this case, a 79-year-old man with elbow stiffness and little finger numbness since the injury 1 year ago. And the X-ray clearly showed us that there was stiffness due to the chronic elbow dislocation. And also the bedside ultrasound found that the outer nerve was thickened and entrapped, and the ultrasound indicate and also locate the course of the outer nerve and reassure the surgeon the position of the nerve before the operation. This is a 54-year-old lady with inflamed elbow, progressive stiffness. The active range was limited to 40 to 90 degrees. The X-ray is adequate enough to show us the diagnosis of osteochondromatosis. However, further imaging helps in the preoperative planning because the CT scan helps us to locate all the loose fragment that we can remove, and also the MR locate the area of the synovitis that we have to tackle to prevent the recurrence. Finally, the patient had the arthroscopic removal of the loose body and synovectomy performed. This is her condition day 1 and 3 years after the operation with no obvious recurrence of the disease. This is a 56-year-old lady with an elbow dislocation, initially treated conservatively with physiotherapy, but the elbow was very stiff. There was progressive ossification, mild ossification around the MCL and radiocollateral ligament. And 3 years later, because of the stiffness, she underwent arthroscopic release by another surgeon, but the result quite similar. This is her condition 4 years later. The CT scan is helpful, which revealed that there were ossified form at the side of the olecranon and around the fossa. With the help of the CT scan, pathology could be adequately located, and the possible outcome could be predicted and discussed with the patient before this second operation. Arthroscopic removal of all those impinging bone, capsular excision was done thoroughly. She achieved good range of motion after the operation. This is a 40-year-old man with poorly controlled diabetes, road traffic accident, and open comminuted fracture of the olecranon. The fracture was not well fixed, the alignment was not satisfactory, and was later complicated with osteomyelitis and septic arthritis and wound infection, and he needed a long period of antibiotics. This is the X-ray showing in the 3 years' time, showing there's non-union of the proximal ulnar. And so the bone graft was performed from harvest from the iliac crest and put it in non-union side. Seems that the fracture sites have passed to union. However, this patient was 9 years after the injury, still complaining some posterior elbow pain with stiffness. And he said that the range was not painful at the mid-range and he was not painful in carrying heavy weights, but there was mild tenderness at the posterior ulnar humeral joint and also tenderness at the olecranon non-unit on fracture site, and also there's a bony percussional tenderness there. Posterior impingement tenderness was positive. The blood result did not reveal any features of infection. The MRI showed that indeed the fracture site is still non-united, and there are also arthritic change over the ulnar humeral joint, and also all small ossify at the olecranon tip region. The pain could be arising from the ulnar humeral joint, from the non-union site, or from the olecranon tip ossify at the displaced proximal ulnar. So we cannot know the reason for the pain, so we try to do the injection test of small leg locaine over the olecranon tip region. The patient said there's only mild improvement in the pain, but at the non-union site, the patient said the pain markedly improved. So healing of the olecranon may potentially improve his elbow pain and favor further possible intervention for the arthritic elbow if necessary. However, fixation of the proximal ulnar in this case may not be easy. The patient has soft bone, the shape of the olecranon was distorted, small than thin olecranon fragment, and the fixation may not be guaranteed. And also he has poorly controlled DM with wound healing problem and also thin skin. At this juncture, CT scan is very helpful. You don't only have the CT scan of the elbow, but also at the potential bone graft donor site. It is the pelvic CT scan. Then we can use of the previous bone graft harvest area on the right iliac crest, and the plan for the corticocancellous bone graft over there, which was the previous bone graft donor site, and then a matching size graft were planned to be inserted at the olecranon around the non-union site. Discs were made. A corticocancellous graft was harvested from the right iliac crest and donated to the olecranon after the bone tunnel was made over there. This is his condition 4 weeks after the operation. Hope the fracture can finally heal. Imaging is also helpful to guide us to choose the treatment modalities. This is example with the olecranon fracture, radial head fracture, and he has the limitation elbow range and the form pronation range. And the CT scan let us know that the implant was not the source blocking the elbow motion. Therefore, arthroscopic removal of those fibrotic tissues, scarring, and heterotopic bone was already adequate to improve his elbow range of motion. Then he doesn't need have an open surgery. Then he can enjoy an easy post-operative rehabilitation, achieve good range of motion. This is the 48-year-old man with tricep avulsion fracture 1 year ago. He said he had no elbow pain, the tricep power was full, but he requested a better range of motion. X-rays show that the tricep avulsed bone already healed with the olecranon at the distance, but it overgrew as a heterotopic bone at the back of the elbow, blocking the extension. MRI is helpful and show that the heterotopic bone encased in the tricep tendon and impinging on the posterior elbow. If handling this condition in an open way, it's likely that the tricep tendon needed to be repaired and protected after the operation, which may also hinder the rehabilitation of the elbow range gaining. However, this patient has no posterior elbow pain and a good tricep function, so arthroscopic removal of the impinging bony part seems adequate enough and make the operation simpler, and the patient could play badminton happily. This patient is 28-year-old. The forearm locked in the supinated position after the injury, and the elbow flexion range was markedly limited. So the X-ray clearly showed that the radial head anterior dislocated and there was heterotopic bone attached on the radial head and at the middle side of the elbow. In this juncture, a dynamic X-ray is very helpful to give further information about the elbow and forearm motion in related to the heterotopic bone, and also let us know whether there was mobility between the heterotopic bone and the radial head, and also know the degree of the MCL laxity. With the radial head encased in the heterotopic bone, the cartilage was rarely preserved. The benefit of salvaging the radial head was questionable. Moreover, at the same time, the MRI is helpful to let us know the medial collateral ligament, both the anterior and posterior bundle, was badly torn with fibrosis there, and the radial head cartilage was damaged with the distorted shape of the articular surface. And also the interosseous membrane, also with fibrotic changes with the heterotopic bone over there. So the radius will be very difficult to be reduced into its original place. So finally, patient have the radial head removed, and also heterotopic bone removed, reconstruction of both the anterior and posterior bundle of the medial collateral ligament. This is his condition 4 months later, and also 2 years with no features of the medial collateral ligament laxity. Imaging is also helpful to help us to predict the treatment outcome. So this is a 10-year-old girl with a distal humerus fracture with a trans and intercondylar fracture fragment. Unluckily, the fracture was not reduced properly. You can see the fragment was too much anterior angulated. And then the patient have persistent elbow stiffness, unable to bend the elbow beyond 10 degrees. Then he underwent an open surgery for the release, and then complicated with ulnar nerve palsy, and then with the ulnar nerve release performed again. And this is her condition at the time she saw me, which is already 1.5 years after the operation. The elbow range of motion is only 20 to 25 degrees, and the X-ray showing there's a deform of the distal humerus, including the capitulum and also the trochlea. And then the patient underwent an operation arthroscopic release in the United States, and the elbow range was very good after the operation. However, this is her condition 6 weeks after the operation, and the elbow range was returned to not a satisfactory condition, although it's much better than the initial time. And then she was found to have the features of radial nerve entrapment by the tricep. So the leg looking test was also performed again, and also at the same time, steroid was injected to the posterior aspect of the tricep and to the radial nerve. Despite with the effect of the leg looking, the patient had weakness in the wrist extension, but she could bend the elbow very nicely. This is her condition on the right-hand side, showing the 2 months after the injection. This is her condition 1 year after the operation. Her parents still asking whether she can get a better range after this. At this juncture, MRI of both elbows was very helpful for the comparison of the elbow normal anatomy. So this is a 3D printed model from the MRI, and it helped to assess the range of motion in a malunited fracture. It revealed that with the elbow flexion of 110 degrees, there was impingement of the radial head onto the capitulum. If the elbow was bent further to 125 degrees, the impingement of the coronoid process on the coronoid fossa was also found. There was also widening of the posterior aspect of the radial capitular joint. With this malunion of the distal humerus, further arthroscopic release would not be helpful to improve the range unless much of the distal humerus bone had to be taken down. But the risk of fracturing or producing fibrosis at the raw bone surface in a child and the surgical feasibility and the outcome have to be thoroughly discussed with the parents. This is another case, a 26-year-old lady with Erb's palsy, multiple nerve and tendon transfer for the shoulder abduction and elbow flexion. She had a distal humerus fracture at the age of 8 and limited elbow range. She wished to have better elbow extension for the wedding photo taking. Her tricep power was not bad. And this is her X-ray showing the distal humerus deformed and the trochlea was more oval in shape. And we haven't yet solved the problem of motion artifact in dynamic CT scan. So static CT scan was arranged for her at the maximum flexion and extension, and the elbow models were printed. And we used the 3D scanning to scan the printed model at different elbow angle and simulate the elbow motion at full range of motion in the computer simulation. And we found that at the elbow extension to the flexion around 40 degrees, the animated model showed the significant bone overlapping between the obliquinoid and the distal humerus. If the patient wants to achieve full elbow range of motion, he needs to have removal of the overlapping bone and risking elbow pain and even fracture. So a realistic goal has to be addressed to the patient. So in conclusion, a proper history, clinical exam, and imaging are crucial to identify the culprit causing the elbow stiffness. It helps us to choose which treatment is the best for the patient and help in preoperative planning and predict the treatment outcome. And we also need to have a good understanding of the patient major concern and know the patient expectation. The decision on the surgical approach should be individualized and the realistic goal should be addressed to the patient. So that's all for my presentation. Thank you very much.